be demonstrating the palpation and injection techniques in the lower back, sacral area, and then the hip, followed by the anterior portion of the pubic bone and the adductors. It's very important to have the patient positioned properly for this. As we can see with our demonstration model, we have the patient flexed over a pillow that's directly under the hips. This serves the purpose of elevating the lumbar spine and reducing the lumbar lordosis, making our palpation and our injections easier in this area. Again, this pillow needs to be crossways under the hips and not under the stomach, but low enough so that you can get that reduction in the lumbar lordosis. We'll now look at our palpation and marking of the lower back, lumbar spine, and pelvis area. We, of course, have the pillow crossways under the pelvis to elevate the pelvis and reduce the lumbar lordosis. We begin our palpations by identifying our midline, and we'll just mark some of the spots over the spine in the midline. We want to come clear up into the lower thoracic area. The 11th and 12th ribs are areas that are often tender, particularly the 12th rib, because of the attachments of the quadratus lumborum onto the 12th rib. So we can palpate and find the 12th rib right here. And when we're injecting that, we of course lock the rib between our fingers and do our injections that has been demonstrated in our rib injection series. So our palpation needs to come clear up into the lower thoracic area, the T11, T12 area, as this can be a common area of involvement with lumbar problems. We begin by identifying the spinous processes, and we can feel a spinous process right here, and the spaces between the spinous processes. There's a space. Sometimes it's hard to feel these areas directly, especially in patients who may have more padding in these areas than our current model. And so it may be not possible to feel directly where these areas are. It's important to do our palpation and our marking in the same position that we will do our injections. If we do our marking and then switch positions, we'll find that the marks have changed places. Coming on down, we can feel our interspinous areas and our spinous processes. And again, sometimes this is more of an approximation because we can't actually feel very well the bone itself. It's then important to identify when we're down to the L5-S1 area. And it feels to me like this is L5-S1 right here. Spine right there. And again, sometimes it's hard to tell for sure. We know, of course, that the level of the iliac crest is often equivalent with the L4 area, but it can be difficult to differentiate which spinous process we're at sometimes. Our next markings will be the level of the facets. And in the lumbar area, we know that frequently the facets align with the interspace, the space between the spinous processes. I remember this by thinking of it as space to space. In other words, space between the spinous process aligns with the space of the facet itself. And so we can mark those areas, and those are approximately 1 finger breadth off the center of the spine. And again, remembering that the facet itself is not what we're trying to hit. We're trying to hit the capsule, the ligament structures around it, and so we're going for that area in general. Our next landmark will be at the edge of the muscle mass that comes down and spreads out onto the ilium here. And as we come out and we drop off that, we know that the tips of the transverse processes will be right in that area. And they will be in line with the tops of the underlying spinous process approximately. So we find that edge of the mass there, the muscle mass, and we can look at the top of the spinous process and find that it's going to be roughly in that area that we'll find the tip of the transverse process. And this one we're moving down is going to be under the ilium in this area. And so the L4, L5, sometimes L3 tips of transverse processes will be tender, and we can push in and find the tenderness in that area over the tips of the transverse process. The iliolumbar ligament comes up and attaches to the L4, L5 tips of the transverse processes. Our next landmark will be the iliac crest itself. We want to start quite lateral, remembering that in many patients there will be pain clear out in the lateral area, and then we begin to get into the area where the lumbodorsal fascia attaches. And we carefully palpate along, feeling for tenderness. We'll mark the edge of the ilium. And it is important always to do marking on patients, again, in the position that you're going to be doing the injections. We're following the edge of the ilium down until we come to the PSIS, which is this whole ridge along here, and finally the bottom of the PSIS, the posterior superior iliac spine. And to find this, we want to do a lot of skin compression, pushing in very firmly, and then coming up underneath the PSIS like this. Sometimes it's hard to feel that bottom bump of the PSIS, so again, by coming in with skin compression and pushing upward, we run into that bump of the PSIS right there. We remember that the back side of the PSIS has gluteal attachments on it and comes back around like a backward C like this. Our next landmark will be the edge of the sacrum. As we come down, we palpate, and it should be right off the bottom of the PSIS, coming down at an angle, finally to the angle of the sacrum, which comes around into the coccyx, which is deeper in and more in the midline. These are the important attachments of the sacrospinous and sacrotuberous ligament. In thinking then about the ligaments in this area, we have the important lumbodorsal fascia coming down and attaching all along the edge of the ilium here. It's a very large fascial sheath that when you dissect this in a cadaver, you can literally pick the cadaver up with that lumbodorsal fascia. Attaches very tightly on here. And that's a frequent area of pain right along the edge of the ilium. The iliolumbar ligament, which attaches in this area with an anterior portion that goes down anteriorly to the sacroiliac joint, and then the posterior portion that comes up and attaches to the tips of the transverse processes at L4 and L5, coming over like this, and that's why it's important to hit those tips of the transverse processes as well as that iliolumbar ligament in that area. Our next areas will be the posterior sacroiliac ligaments and the deep interosseous ligament, which is right above the sacroiliac joint and fills that whole space between the ilium and the sacrum down into the area right above the sacroiliac joint with a very tough, thick, fibrous ligament. These are the areas that Hackett has named Area A, Area B, Area C, and Area D, points around the bottom of the PSIS. Looking at our ligaments then in the sacroiliac area and down around the PSIS, we remember that we're looking at the deep interosseous ligaments, the iliolumbar ligament, and then the posterior sacroiliac ligaments with the areas that Hackett has named as A, Area B, Area C, and Area D around the bottom of the PSIS. These areas are carefully palpated, both feeling on the PSIS and in the cleft between the ilium and the sacrum, the fibers of the posterior sacroiliac ligament, all the way around, carefully palpating and noting tender areas all the way around the bottom of the PSIS. It's important to note that the bottom of the PSIS is frequently a very tender area. And that's because we have a huge amount of ligament coming in and attaching onto the PSIS from the sacrospinous sacrotuberous, the biceps femoris, transferring force right up through this area in combination with the posterior sacroiliac ligament. And this is a big bump for a reason, and that's because there's a lot of force being put on it. We then carefully palpate around the backside of the PSIS, the reverse part of the C here, if you will, and that's also often a very tender area. We're now moving into the area of the gluteus muscles, the gluteus maximus and the medius, and it's important to palpate along the ilium, right down, and feeling the line down along the ilium, which is often tender areas throughout the gluteus. When you dissect these muscles out, there are multiple tiny attachments of the gluteus into the ilium, small little fibers attaching all through this area, so our injections need to be carried out carefully throughout this whole area, peppering this area. Our next landmark is the sacrum and the sacrospinous and sacrotuberous ligaments coming in and attaching on the sacrum itself. They attach at the side of the sacrum and underneath it, and so we're looking at palpation as far as we can laterally along the sacrum. Again, carefully palpating with each individual point so the patient doesn't get confused with our whole hand on it, but each individual point being palpated, and asking for areas of tenderness in this area. We can also palpate the coccyx in this area, and patients will tell you if they have coccygeal pain, so we know to feel that. When we come down to the trochanter, we want to palpate the top of the trochanter on the side here, and we know from that area up to the bottom of the PSIS, anything above that area is going to be bone and safe to stick our needles in. Below this area, we of course run into the space here where the sciatic nerve comes through, but it's really very hard to hit the sciatic nerve, and if you do hit it with a needle, people will tell you about it. But this is a safety feature to stay above this line with your injections when you're doing this particular area. Our injections then in these areas are carried out in the same way that we mark in a very meticulous manner. Looking at the lumbar spine, We can feel the spinous processes themselves, and then we come always in a caudal direction. We don't want to come in a cranial direction here, but in a caudal direction or a nearly straight in to hit that spinous process. We lock our fingers over the spinous process so that we can feel it directly. And then we come in, and it shouldn't be a deep injection, especially if we're pushing the skin in with our skin depression, right into that spinous process and do our injection of half cc of solution. We can then come back out with our needle and feel the interspace between the spinous processes, and then we can come down into that interspace and inject onto the top of the spine of the next spinous process. The interspace between the spinous processes is the interspinous ligament, and the supraspinous ligament is on top of the spinous processes. There are injectors who inject both inferiorly or caudally on the superior part of the spinous process, and then reverse the needle and come up in a cranial direction on the underside of the spinous process. Other injectors feel that it's adequate to just do the injection in a caudal direction and that this is safer to do. You have less chance of doing an inadvertent spinal tap or hitting the cord in this area. These injections are continued right on down until we get to the L5-S1 area. And the L5-S1 area can have a broad opening where the dura mater can come right up into that area. So we usually don't recommend an injection into that space because of the risk of doing an inadvertent spinal tap in this area. Our next injections are carried out into the facets. And as we recall when we were marking our anatomy, if we feel the interspace, that area between the spinous processes, we can come down about a finger breadth off the spine and come either straight in or with a little medial angulation down until we hit that area of the interspace, realizing that we're not attempting to get into the facet itself, but we're attempting to inject the capsule, that ligamentous tissue that supports that facet and holds it together. We can also, if we wish, walk our needle off the edge of that just to orient ourselves to the space a little bit closer. This is an injection of approximately a cc in each facet area. Again, remembering that we're not entering the facet here, but we're entering the area of the facet so our solution flows into that tissue. Our next injections are carried out on the iliac crest itself. This is very important, and if people have tenderness clear out in the lateral part, you can do that in this position with a lot of skin pressure down and then coming in with your injection onto the top of the iliac crest. It's surprisingly hard to hit sometimes, and so sometimes I'll turn the patient on their side, which elevates that portion of the iliac crest and allows me to hit it more easily. When you get down into this area of the ilium, then we do again skin compression onto the ilium and come down with our needle onto the top of the ilium, hitting the top of the ilium, that iliolumbar fascia that runs all the way along the ilium in this area. Once we've injected the iliolumbar fascia along the ilium, then we need to go deeper in and inject the beginning fibers of the sacroiliac ligament and the iliolumbar fibers that are deeper in this area, as well as getting into the deep interosseous area above the sacroiliac joint. This can be accomplished in a couple of different ways. One is to come into the ilium itself, touch the bone, and then slide your needle off of the bone and underneath the ilium, curving the needle under until you hit the bone deeply underneath it. The other way is to move our injection site about halfway between the spinous process and the ilium at the level of L4, and using a 3-inch needle, coming in and injecting laterally underneath the ilium so that we come down into that deep cleft where the interosseous ligament is, and moving our needle around in this area doing our injections. Frequently, when you're down deep into this area and you inject, people will tell you that they feel a warm feeling or a little discomfort in their leg, which means you're in the right area when you inject into this area. We then need to inject our tips of our transverse processes, and as I mentioned, they are out at the edge of the muscle in line with the top of the spinous process. So we come out, and with our needle aimed either straight down or usually a little medially, we come in quite deeply. It's often surprising how deep these transverse processes are. If we don't hit it in one spot, we either move a little bit caudally or a little bit cranially and try again. We don't want to go above the level of L3 with our transverse process injections. We then move down to our posterior sacroiliac ligament fibers that come in and attach on the edge of the ilium and then down deep in the cleft between the ilium and the sacrum, areas A, B, and C. And these fibers are hit by coming laterally, aiming at the iliac crest itself. We want to keep our fingers on the iliac crest so that we always have orientation of where that edge is. We can roll our fingers over the edge, and then with skin compression, coming in and finding the edge of the ilium and hitting it, and then walking with needle orientation coming out to the skin and then back in again, walking 2 or 3 times with each injection along that ilium, and then sliding off and going deeper into the deeper cleft between the ilium and the sacrum to get the deeper fibers of the posterior sacroiliac ligament at areas A, B, and C. So again, we're hitting the ilium, then coming with 2 or 3 injections directly on the bone, sliding a little deeper and going under, but always injecting on the bone with 2 or 3 injections at each place. It's important to know where the spine of the sacrum is, and then to avoid this middle area where the foramina in the sacrum are. We never want to put our needle into this area straight down because you can get into a foramina and cause nerve damage. Some injectors will reorient their needle and inject medially onto fibers next to the spine, but I think most injectors are just focusing on the lateral portion of these fibers as that's the area that seems to be tender the most frequently. We then come around to area D, and we have to reorient our needle as we come around this way, thinking about the anatomy so that our needle is oriented toward the spine to hit bone in this area. And again, using the techniques either of skin sliding and doing multiple injections or reorienting our needle a bit, we need to do multiple peppering of this tissue. We come up along the back side, that area that tips off the back of the PSIS, and inject thoroughly along this area. And then we begin our injections in the gluteal muscles by coming with a lot of finger pressure down, pressing in on the tissue, and coming in, remembering that the ilium drops off fairly dramatically here, so that if our injections are carried out downward like this, we'll just slide off the side of the ilium. Our needle has to be oriented medially, and the further down we come, the more medial our needle has to become, so we're just almost directing our needle straight toward the spine when we get down laterally on the ilium. Again, I usually do these injections with 1 injection coming out to the skin line, skin sliding down, doing another injection, coming out to the skin surface, skin sliding up and doing another injection, or by injecting and reorienting my needle just a bit in 3 or 4 different directions to pepper that area thoroughly along the gluteus attachments. Our next area of injection is down on the sacrum itself. Remembering that the sacrospinous and sacrotuberous ligaments come in and attach on the lateral part of the sacrum. So we want to come in and find the real border of the sacrum, sometimes by coming in with just a little bit of a medial angle till we hit the border of the sacrum, and then walking off and letting our needle drop off deeply so that we know we're right at the edge of the sacrum. Doesn't do us any good to inject on the top of the sacrum here. We want to be right at the edge. The other thing to do with this is to really push the tissue in very, very firmly and come in from a lateral direction, getting on the lateral border of the sacrum as we walk down in the attachments of the sacrospinous and sacrotuberous ligament in this area. It's also possible here to do the posterior part of the trochanter. And we'll be talking about the trochanter and hip injections in a bit, and to hit the posterior capsule of the hip. Frequently this is a tender area. If you find the trochanter and near the top of it, come down just a hair and then push in very firmly, people will often have tenderness, and this is the posterior capsule area of the hip. So we can come right into this area and hit the posterior capsule of the hip itself with a usually a 3-inch needle is utilized in this area. The ischial tuberosity is a frequent site of pain as well. People complain of pain sitting, difficulty with walking with this. And so to inject this, we either have the patient prone, as our model is, and we come in very firmly until we feel the ischial tuberosity. And again, feeling the areas of tenderness here are very important. The biceps femoris hooks into this area, and the semitendinosus, and then the membranosus further in, but the semitendinosus medially on the ischial tuberosity. We then keep our fingers pressed firmly in, because there's a lot of tissue here, and come in directly with our needle onto the ischium and walk around with our needle, coming out to the skin level to reorient and do the skin sliding in this way. This injection can also be done with the patient in a knee-chest position, or with the patient on their side with the knee drawn up, and sometimes in larger patients that exposes the ischial tuberosity and makes the injection easier. To demonstrate the injections on the skeletal model of the lower back, we remember again finding our anatomy, the spinous processes, the interspinous areas, spinous process, interspinous area, and our discussion about the facets being in line with the spaces, which in this particular model they are not, they're above the space, but we're in the facet area when we're in that area of the interspace. So our first injections are carried out with our fingers firmly planted on the spinous processes, coming down in a caudal direction, and then coming into the interspinous area, coming again in a caudal direction to hit the top of the spine. Again on the spinous process, the supraspinous ligament, the interspinous ligament, supraspinous ligament, all the way down to L5, but then remembering that we don't want to inject at the L5-S1 area because the dura mater can protrude in this area and come up into here, making a spinal tap very easy to do. Our second line of injections, as we mentioned, are a finger breadth off of the spinous processes, and we're injecting down onto the facet area, keeping in mind that generally the facets line up the space with the space between the between the spinous processes, so that by coming down in a straight down direction, or perhaps a little medial angulation, we're hitting that capsule around the joint. We're not getting into the joint itself, unless we're very lucky, but we're hitting the capsule area around the joint. Coming down, hitting it, coming down to our next level, hitting it, down to our next level, and hitting that area again. We then think about the line of the transverse processes, and we find them at the edge of the lumbar paraspinal musculature. There's a drop off there, and we come in with our needle and hit the tip of that spinous process at L3, 4, 5 or 4, 5, which is where the attachments of the iliolumbar ligament are, coming up from the edge of the ilium down here. Our direction of our needle is slightly medial, and we can actually hit the bone and then walk off it and come back to the tip of the bone as close as we can to the tip of the bone. If we don't hit it here, we find there's a lot of space here, and so we may wish to redirect and go down a little bit or up a little bit to hit that tip of the transverse process. Our next line of injections is the line along the ilium. We can see that laterally we have muscular attachments, medially we have more fascial attachments in the lumbar dorsal fascia, all along the ilium, coming along the top of the iliac crest, and then sliding our needle down underneath the iliac crest so that we hit the attachments of these ligaments all along this area underneath the ilium. We can see on this model how rough this is, and that's because these are all ligament attachments down in this area. We then come with our needle either deeply sliding over the ilium into that area, or with a longer needle from between the area of L4, L5, about halfway between there and the ilium, and sliding our needle in so we come directly down into that deep innominate ligament that's deep in right over the sacroiliac joint. And as we mentioned before, this is often an area when you're down in it injecting that people feel a warm sensation or a sensation in their. We then think about areas A, area B, area C, and area D of Hackett. And so we're injecting on the ilium itself and then more deeply down into the sacroiliac ligaments with multiple injections into this area on the ilium, as well as deep down into the sacroiliac joint area. We then reorient our needle, coming around in a more cranial direction to hit the bottom fibers of this, points C and area D. We then remember our lines of injections along the gluteus, attachments of the gluteus maximus and medius, and we do fanning of those injections, keeping in mind that as we move down the ilium, if our needle is directed in this direction, we're just going to slide off the ilium and not hit anything, so that we have to reorient our needle coming in so it's perpendicular to the bone. If one can imagine in one's mind's eye the direction of the bone and keep the needle perpendicular to it at all times, this is helpful. We mentioned that the line between the top of the trochanter and point D, or the bottom of the PSIS here, is a line right along here, is a safe area to inject. You'll be out of the sciatic nerve in that area, and you can inject on bone all the way above that. We look at the attachments of the sacrospinous and sacrotuberous ligament. we see this huge ligamentous structure which blends the sacrospinous and sacrotuberous ligament together and comes in and blends into the posterior sacroiliac ligament. To inject the sacrospinous and sacrotuberous ligaments and their attachments on the sacrum, we have to push the tissue down quite firmly, come in, and hit the edge of the sacrum. If we miss it, we may be too far over, or we may be sliding over the top of it. So what we can do is feel where the edge we feel it is, and then come straight down with our needle until we hit the edge, and then walk in this direction off until our needle drops off, and then orient our needle onto the side of the sacrum to hit that point. The coccygeal injections are actually very easy to do because most of the time people have very specific tenderness on the coccyx in the areas that they are finding painful to sit on. So you can come in and just hit those little areas, and they're often very tiny areas right on the bump of the coccyx. It's also possible to put people in a knee-chest position and to put your finger in the rectum and do your exam with the finger under the coccyx, pushing up to get better access to the coccyx itself. You can also do a rectal exam and feel the sacrospinous and sacrotuberous ligaments in the rectum and come with your finger on those ligaments directly in until you feel the needle pressure, being careful not to go too far, and injecting into the attachments of those ligaments right onto the sacrum as your finger palpates that area from the rectum. In injecting the lumbosacral area, we can stand to the side of the patient and a bit caudally. We can then carefully palpate the spinous processes, the interspinous areas, and then with our fingers locked over the spinous process, coming directly down onto the spinous process, doing skin sliding or re-entering with our needle into the interspace between the spinous processes in a caudal direction with our needle. Again, the next spinous process all the way down to L5, but being careful not to go into the area between L5 and S1 as the dura mater can protrude into this area, making it easier to do a spinal tap. Our next line of injections are into the facets or the facet area that we can see here. Again, we're not attempting to enter the facet directly, but really the capsular area around it. We know that in most patients, those facets lie in a direct line with the interspace, so that if we come a finger breadth off and down into that area, we will be in the area of the facet capsule. We need to be careful not to go too medially. It is possible to hit nerve roots in this area, so we need to take care, if we don't feel the bone, to come back out, redirect our needle a bit, and find the facet area. It's also possible in this area to inject the multifidi that attach to the side of the lamina by holding on to the spinous process and then directing our needle medially directly into a line below our finger and thumb so that we hit the side of the lamina here. We need to be careful in doing this not to direct our needle caudally or cranially so that we might do an inadvertent spinal tap. But it's a very safe injection if we're careful to go directly in underneath our finger that's attached to the spine. In addition, we wish to inject the tips of the transverse processes at L4 and L5. These are the attachments of the iliolumbar ligament, which we can see right here, coming up and attaching to the L4 transverse process and the L5 transverse process. The injection is carried out by feeling the edge of the paraspinal muscles and then going in, and this will be about 3 finger breadths off the spine, going in a little bit of a medial direction, keeping in mind that often these are in line with the top of the spinous process, but there's enough anatomical variation that you may or may not hit it with that. Going in as far as you think safe, coming back out, redirecting the needle a little to the south or to the north to try and find that tip of the transverse process. Our next line of injections will be along the iliac crest, and the iliac crest points can come all the way out to the lateral iliac crest, in which case it may be easier to place the patient on their side so that's elevated. Posteriorly, you can easily hit it from this direction, placing your fingers along the ilium and then coming in with the needle directly onto the iliac crest, again fanning your injections all along it in a peppering fashion. In addition, we can push the tissue down and or slide the needle underneath the ilium and feel it slide along the ilium, injecting the bone on the underside of the ilium, going down all the way down into the deep area of the cleft between the sacrum and the ilium, right down in here. And we can see the firm ligament that's part of the interosseous ligament down in this area. We can also reach that point and that area of the deep interosseous ligament by going approximately halfway between the spine and the ilium at the L4-5 level, and with our needle directed in a caudal and lateral direction, sliding into that cleft, getting deep in and again hitting bone. Injections in this area will often cause a warm feeling down the leg or a sensation down the leg. But this is an important area to hit that deep interosseous ligament. We then move on down the spine. We can see the roughness in this model, and that's because ligaments attach in this area. And we hit the areas along the spine itself, area A, area B, area C, and area D. We then drop deeper in to get the posterior sacroiliac ligament fibers, injecting 2 or 3 directions with each needle stick. It's important to stay lateral with our needle aimed laterally and avoid coming in the midline halfway between the spinous processes and the ilium, because we have the openings that can lead directly into nerves here and cause nerve damage, our foramina. Occasionally, you'll find tenderness medially, and if we do these injections, we need to aim directly toward the spines for the medial fibers. Most injectors don't do that as a routine, but it is an injection that's possible as long as you stay out of the midline. We come on down to area C and area D, and we can see how huge these ligaments are in this area, so that we're really coming in an upward direction and peppering that whole area around areas C and D with multiple injections. If we come down on the ilium here, that's fine as well. We also are going to be coming along the back side of the PSIS, a very important area to inject as we come back up. Even if you don't do the gluteal attachments out here, you need to do this back side of the ilium here. The attachments of the sacrospinous and sacrotuberous ligament, the sacrotuberous ligament here originating on the tuberosity, and the sacrospinous ligament under here originating on the spine of the pelvis here, coming up and attaching on the lateral border of the sacrum and blending into the posterior sacroiliac ligaments. This really is a huge mass of ligament, and so injecting all in it is valuable. We feel the edge of the sacrum, realizing that that's often the perceived edge rather than the real edge, since there's a lot of tissue between us and the bone. We push down that tissue as much as we can and come in a lateral direction to medial, trying to find the very edge of the sacrum, which is where those ligaments attach on the sacrum itself. If we can't find it, we can come back up and come in a straight down direction and move medially until we hit the edge of the sacrum. Then, Once we found the edge, drop down so that we're catching the fibers along the lateral border of the sacrum. Again, to demonstrate that, we come down until we hit the edge of the sacrum with our needle, and then we come in laterally and hit the lateral border of the sacrum from this direction. This requires a lot of tissue being pushed down out of the way so that the needle can get in and reach that lateral border. To inject the trochanter, it's best to have the patient lying on their side. This elevates the trochanter and makes it easier to find. The trochanter can be surprisingly difficult to find. You feel it, but when you try to inject it, you just slip somewhere where there's nothing. So it's best to try and find the top, the front, and the back, and to carefully palpate all around that area. Frequently, I think people make the diagnosis of trochanteric bursitis by just pressing on the trochanter in one spot and saying that's trochanteric bursitis. I believe that trochanteric bursitis is a vastly overrated diagnosis, and that most of the time this represents ligament pain that involves the front, the back, all down the trochanter and down the femur, a third to halfway down the thigh in the tensor fasciae lata. So once we think that we found the edges of it, then what we do is again carefully palpate all around the trochanter as we go right around it, and marking tender areas, which usually is all around the front, all around the back, and then right down the middle, clear down the femur, again half to a third to halfway down the femur. When we're injecting this area, then, we need to find as close as we can to the top of the trochanter, and we need to come in with our needle and then come back out to the skin level, slide up in again until we drop off the edge of the trochanter. Once we've marked where that is, then it's easier for us to find our orientation and accurately find the edge of the trochanter and inject around the edge and around the front edge, and then down the middle, even with 2 rows, through the middle of the trochanter, and then following the femur down by using skin compression, because the femur is not very wide, right down the femur where the tensor fasciae lata runs right down the side of the femur. This is a convenient position also to do our intra-articular injections, and once we found the top of the trochanter with our needle and done the injections in this area, with the legs slightly elevated at the knee with a pillow between the knees, this elevates the leg like this and makes it easier to enter the joint. We of course aseptically clean the area that we're going to inject. We come off, we can find the top of the trochanter and then slide off the top of it and slide our needle down, and we'll be in the hip joint. You can feel it pop in and then feel bone, and an injection in this area of 25% solution is required. The solution should flow freely into this area, and the patient shouldn't have pain, as with all intra-articular injections, when we do the injection. Again, it's very important to remember not just to do 1 or 2 spots on the trochanter, but to carefully, in our usual peppering fashion, pepper the entire trochanter. We talked about the posterior capsule, and we can see here that this is the area where the posterior capsule attaches. We find the edge of the trochanter, the posterior side of the trochanter, come back from it into this depression, and we find that just medial to that, we aim our 3-inch needle down into that depression where people are tender, and we're injecting along the posterior capsule in that area. To inject the trochanter itself, we need to turn the patient on their side, and again we feel all along the back of the trochanter, the top of the trochanter, and the front of the trochanter, as well as down the middle of the trochanter and down the femur. And then our injections should be carefully done all along those areas, covering as much of the trochanter as we can. And injecting then with our fingers locked over the femur, injecting right down the edge of the bone. We're now going to be doing the anterior part of the hip and pelvis area. The first part of this is to orient ourselves anatomically. We need to find the pubic symphysis and follow over the pubic ramus. We know the pubic symphysis in the middle here. Coming down on it from above is an excellent way to orient ourselves on that. We then come across the pubic symphysis and mark the ramus right across. And then we orient ourselves by finding the anterior iliac superior spine right here. And we know that below that and down is the inferior spine right there. The attachments of the rectus femoris come up onto the inferior spine. Sometimes you can feel down directly on it and feel it. Other times it's a bit indistinct, and to inject it you just have to approximate the area, remembering that it's about 1 centimeter over and down from the superior spine. The next orientation that we do is coming across with a line directly in line with the pubic symphysis, and then a line down from the anterior superior spine. It's in where these cross that we're looking at the hip capsule and coming into then the anterior capsular ligaments of the hip. So we'll start our injections in this area by coming down onto the pubic symphysis. Often this is a tender area right at the symphysis, but even more frequently I find that it's tender all across the ramus. In our skeletal model then, we're looking at the hemipelvis here with the pubic symphysis right here, the center, and the ramus across with the adductors, the longus and brevis, and the pectineus attaching here, and then into the capsular muscles, or the capsular ligaments rather, that come up from the hip itself and attach to the pelvis in this fashion. Again, the superior spine here and the inferior spine here with the attachments of the rectus femoris here, the attachments of the sartorius on the superior spine here. So we're going to be locking the pubic symphysis between our fingers and coming down directly on it with our needle, moving over and marching over as far as we can to get the beginnings of these ligaments in this area. And you really push down quite firmly, and you'll find that people are tender right along that area. And again, this adductors and these ligaments kind of combine to form this tissue along the ramus here. So we walk across as far as we can feel, and I can still feel ramus right there, coming down into that area, and just injecting small amounts of solution all across the pubic symphysis. We then feel the artery, which we can feel right here, and we know from our markings down from the anterior superior spine and in line with this that we want to avoid the artery, and so we come lateral to that and come in this direction toward the midline of the body and so if we orient ourselves on this model, we can see the ASIS here coming straight down in a line here and straight over in a line like this. We meet right here, and so our artery will be running right here, and our needle then will enter and slide in under the artery and coming into the capsular ligaments like so. Again, important to always feel bone and inject on the bone in this area and going underneath the artery and nerve and vein that we know are medial to our needle entry point. The anterior superior spine, if it's tender, and the inferior spine should be injected as well. More often, the inferior spine seems to have tenderness than the superior spine. Another area of injection on the pelvis is down along the pubic bone here, moving down from the pubic ramus onto the attachments of the adductor magnus down in this area. To accomplish this, we have the patient bring their leg up and lay it out and just relax. We then come in and find the pubic symphysis again, and then the tendon of the adductor magnus right here, and then we need to come in fairly deeply, and there we're right on that bone below the pubic symphysis right in here. And in people who do skiing, jobs where they're spreading their legs and lifting, these are often very, very tender areas. And so in addition to injecting along the ramus of the pubes, we need to come into this area right down to the adductor magnus and carefully pushing the tissue in quite firmly and then coming in with our needle, and it won't be a very deep injection into this area.